This is Betty Tai. Can you all hear me?
You're doing great, Betty. This is Liz.
All right. Good afternoon, everyone. This is Betty Tai. I'm the director for NIDA's Clinical Trials Network. And it is my distinct pleasure to meet you online to discuss the importance of NIDA's Clinical Trials Network. And thanks to the new era of the web technology and our coordinating centers forward planning, so we can have this virtual meeting so that we can have this discussion, and yet we don't have to leave our workstation. It is amazing how computer and internet have changed our way of life. So let me start with a little bit historical background of the CTN. In all therapeutic areas, there is a gap between research and the practice, and it is not different in the treatment of substance use disorders. And in 1998, IOM published a study report to reveal that the wide gap between drug abuse research and drug treatment is the major reason for lack of advancement in drug treatment in this nation, and recommended NIDA to establish a research infrastructure to bridge the gap. And the next year, NIDA established the CTN as an enterprise to join researchers and the providers for bidirectional collaboration, and so treatment research may become more relevant to practice, and the providers may become more familiar to the way research was conducted. So in the past 10 years, the CTN was operated under the premises that, number one, addiction treatment services will be improved as evidence-based treatment are broadly implemented in community-based treatment programs. And randomized controlled clinical trials are the gold standard for generating evidence-based treatment. And lastly, but most importantly, to engage the providers in the research process will improve the acceptability and adoption of research results. Now, I'd like to divide my presentation into 4 areas. First, let me share with you the infrastructure of the CTN. As of today, the CTN has 16 nodes and 240 community-based drug treatment programs that covers 37 United States and Puerto Rico. And each CTN node is anchored in an academic center, usually situated in a major university. The center serves as Regional Research Training Center. We call it the RRTC. And then each RRTC is linked with a number of community-based treatment programs. We call them the CTPs. And the CTP serve as the research site. And very near future, in October 2010, the number of the CTN nodes will be reduced to a total number of 13. However, don't be fooled by the total number of the CTN nodes. The truth is, because we have created multi-PI nodes, and so that despite the fact that the number reduced to 13, the actual infrastructure and the personnel involved has been expanded. As you can see, in the future, in our next meeting, we will start introducing many of these new members as added partners and the research sites into the CTN. Now I'd like to share with you about what our drug abuse treatment communities are. As you can see, our treatment community are more diverse than other treatment communities. Within the CTN, our CTPs may be grouped into 4 categories based on the type of services they provide. We have the outpatient psychosocial treatment programs, we have the methadone clinics, we have large hospitals, and high-end rehab centers. All these treatment models encompass social model, behavior model, medical model for drug treatment. For those of you who have participated in our past research activity, you do know that multi-site clinical trials are highly complex research activities. And in order for us to ensure scientific integrity and protection of human subjects in our research activity, we have engaged experienced coordinating centers to support the essential elements for our endeavor. Here is one example of one of our coordinating centers, and we're very lucky in the past that we have had this experienced coordinating center support. From 1995 to 1999, we had the support of DCRI, Duke Clinical Research Institute, and from 1999, we had the strong support from the MS Corp. You see these coordinating centers are an integral part of our organization, and it's usually staffed with highly skilled, specialized experts in supporting statistics, data management, protocol design, and monitoring integrity, security of data, and provide centralized regulatory support, trial monitoring, training, uniform handling of pharmaceuticals, laboratory, and the clinical supplies, and so on and so on. I cannot emphasize more of the importance of our partners here. The next one, it's certainly the last slide, but not the least, are the beautiful people in the NIDA Center for the Clinical Trials Network. I know many of you have contacted us via phone or email. Here is a picture for you with the visual tools of who we are. And in the future, I hope that we will be able to create large pictures of all of you so we can see all of the beautiful people within the CTN. So the CTN Governance Infrastructure is illustrated here with a graph. As you can see, the CTN Steering Committee is really the center, the CNS of the CTN, which represented by 2 members from each node, one from the academia center and one from the provider side. And they share equal rights, voting rights in making all decisions within the CTN. And through several iteration and simplification, the CTN Steering Committee and its subcommittee has been reduced currently into 4, the Executive Committee, Research Development Committee, Research Utilization Committee, and the Publications Committee. And in the past many years, with very strong trust among all the members, and this very streamlined infrastructure has served us very well. Now, I'm moving into the second part of my presentation here is about the research within the CTN. As you can see, this is a very schematic representation of where we stand with all the research we've done in the past 10-plus years. At the present time, we have accomplished 21 studies, and the study results has been analyzed, and publication has been put out, and many of them also have developed into dissemination packages and are ready for people to try it on and being disseminated. And we have 4 studies currently at the data analysis stage, and some of them are actually completed. Their papers are submitted for publication, and once they got published, we will share with you of the results. 3 studies are currently enrolling, and the 3 studies are currently being developed. And for your information, many new concepts have been submitted for the Research Development Committee for reviewing, and a few of them have been selected for further development. So the research activities are continuing and are moving very strong. If we say the CTN is a growing baby, then here's the growth chart for the past 10 years. As you can see, a very healthy pattern of number of completed trials, very healthy pattern of number of patients being randomized. In the papers published chart, as you can see, there's a delay of the growth, but for very good reasons, because it'll take time for the study to be completed and data analyzed and paper get published. And I am very confident that the publication growth will become even stronger in the next few years. I'd like to share with you a little bit more on some of the trials in development. One is the CTN 0037. It's the stimulant reduction intervention using dosed exercise. And this study actually will start imminently, and for those who are participating in this one, understand this is a complicated study, but it's very innovative. The next one is called the SMART ED CTN 0047. It's screening, motivational assessment, referral, and treatment in emergency departments, which is near completion, and I know they are selecting sites. Another one is called CURB. It's cocaine use reduction with buprenorphine. This is testing the potential for buprenorphine, which is partial agonist for mu receptor, and its utility in reducing cocaine use. There were good animal data to support that, and a few human study also suggested the utility, and currently the protocol is in the middle of the development, and this protocol has the potential of being implemented internationally in areas that has a high crack cocaine addiction problem, and yet without effective treatment options. Now, 2 clinical trials currently are in recruitment. One is CTN 44. It's the web-based interventions that will be able to deliver interventions through computer and the internet, and many of you have signed on to that one. Another one is a CCAST, CTN 0046. This study is interesting in that it will test simultaneously conducting intervention for smoking cessation and the stimulant addiction treatment, and to see the interaction of the 2 interventions, whether that would make both treatment outcomes better, or one better, one worse, or both worse. And I think the implication of this study, it becomes very obvious that, because in the past there were controversies about whether you can treat codependence simultaneously. The next couple of slides, I want to highlight some of the CTN completed studies. First, I want to start with the CTN Pharmacotherapy Trials. As you can see, we have tested several different medications. We don't have a lot, but we certainly have the buprenorphine, naloxone combination, and we have tested that quite intensively, extensively in opioid addiction detoxification, and in adolescent tapering, and also for prescription opioid dependence. The second group is to test Concerta, which is marketed ADHD medication, in its utility in enhance the ADHD adult comorbid smokers, or ADHD adolescent substance user. Another group of studies using the NRT patch in drug treatment for nicotine cessation, smoking cessation. And the last study was the bupropion study. That was the one I just told you about, treating the comorbid condition, co-addicted condition. Now, in the buprenorphine trials, as you can see, the CTN number 1 and number 2 are testing the utility of bup-NX in facilitating detoxification when compared to clonidine. And these study results are so overwhelmingly positive, the study was stopped in the middle, and several of the testing CTPs started using this new interventions in their treatment practice, despite the fact that some of the treatment programs initially were very much against the agonist treatment intervention. The adolescent study also has a very good outcome, suggesting that it is safe to use the medication in maintaining adolescents or young adults in this medication, and it really reduced the use of not only heroin, opioids, but also improve the retention and less injecting and less use of cocaine and marijuana in young adults. So these are nutshell for the pharmacotherapy trials. In terms of the prescription opioid study, that study has been completed, papers being drafted, submitted for publication, and we shall discuss the results when the publication comes out. Here is the more detail of the CTN Pharmacotherapy Trials number 10 for bup-NX for adolescents. As you can see, the study was published by a very prominent journal, JAMA. Now, let me provide a highlight of the CTN behavior therapy trials. As you can see here, I listed a good samples of some of the behavior intervention we have tested. Motivational incentive or contingency management. The CTN has modified the intervention, make it a low cost of motivational incentives, and the study 006 and 007 both had very positive results in either methadone treatment settings or in the outpatient psychosocial treatment settings. And because of the low cost of motivational incentives and also the relatively easier learning and training, and this has become very popular, and the study has been packaged into dissemination packages being disseminated by SAMHSA's ATTC. Also, I can shed a little light with you now. We are considering developing a web-delivered training for MI or CM that may be coming out soon. Now, the next intervention I'd like to discuss with you is the motivational interviewing and the motivational enhancement therapy. This has been tested within the CTN in patient population as in adults, pregnant women, and Spanish speakers. I will give you more information on this. And the dissemination package on this one was the MIA-STAT, which was a training a package for supervision to ensure the fidelity of intervention delivery. Seeking Safety is a trauma counseling for women. BSFT is brief strategic family therapy, and BSFT will be published soon, so we can share with you of the study results. Stage 12 is 12-step facilitation therapy. The study has been completed. Data has been logged. We're waiting for the analysis, and we'll definitely share with you of the results. And we also have done quite a few studies using drug treatment programs as platform to study reducing HIV/HCV risk or study the prevention strategy for HIV transmission. So these are the highlights, and I will discuss with you a little bit more specific on a few of the studies for a very special reason. For instance, this MET for Spanish-speaking substance users, this is a study led by Dr. Catherine Carroll and Dr. Jose Chapasnik. And the study has been published recently and has been cited as maybe the top 10 most cited study. So as you can see, the importance of this particular study. This study posed special challenges for the CTN. Number one, it's because we need bilingual investigators and therapists and research associates. And many of the research material must be translated into Spanish, such as consent forms, case report form, assessment instrument, intervention menus. The training has to be conducted in the bilingual fashion, and same with the fidelity monitoring. Despite the challenge, we were able to recruit 436 representative populations of U.S. Hispanics across 5 CTP sites, and the study was completed, results being published. This particular study and its material made it a shovel-ready project for Spanish language international collaboration. I believe and I know that this particular study has been now implemented in Mexico through a State Department-funded project, and the Florida node has served as our liaison working with the Mexican researchers and treatment providers. The next one is an HIV rapid testing and counseling in drug treatment. As you know, recently, the CDC has published the guidelines for rapid testing in medical settings, but the drug treatment programs were deemed as non-medical settings, and therefore this study really provided all the groundwork for establishing the policies in drug treatment. The study basically asking 2 questions. What is the more effective testing strategy to ensure the patient get HIV tested and receive the test results? The second question is, what is more effective testing strategy to reduce the risk behaviors? And this study was very ambitious, recruited more than 1,200 patients, and completed within 1 year. And the study is being written in its manuscript and submitted for publication. As soon as the publication comes out, we'll share with you of the results. The next group of studies are the American Indian collaborations. The CTN has 4 nodes: Southwest Node, Ohio Valley Node, Pacific Northwest Node, Oregon Hawaii Node. Took on this very challenging marching orders and trying to explore how can develop collaborations effectively with tribes and Native American treatment programs. As you can see, the addiction problem is prominent within this special population, and conducting research has many barriers due to the past history, and the CTN is taking on this challenge and with results that will be shared with you soon. Now I'm going to switch to another angle to tell you about additional CTN research results. In order to get more benefits from the research resources, we have encouraged to use the CTN Trials as platform for ancillary studies. And the types of CTN ancillary studies are cost analysis, genetics, training methods, psychometric study, brain imaging study, and many others. I'm just listing a few examples here. And the numbers after the study type are the number of the trials that's being engaged in these ancillary study participation, and various NIDA divisions have been collaborators either by providing additional funding or provide technical assistance. Besides the ancillary studies, as I have mentioned to you, these CTN study data that has been able to provide as a rich resources for secondary analysis studies. The benefits for conducting the secondary analysis studies are such. One, for scientific benefits. Secondary clinical, it may generate secondary clinical useful information. Examples are by additional secondary analysis we can find out, for instance, who dropped out from what intervention, when, and why. Or we can do mediator, moderators analysis and their interaction at the baseline to better guide the patient-centered individual tailored treatment for each of the interventions. And in terms of the scientific benefit, the investigators, especially junior investigators, were able to use these resources to generate research ideas, research publications, and perhaps use this as a background pilot data to apply for further funding. And it also can provide training opportunities for senior researchers to use these data sets as a training for their trainees. And of course, economically, this is a relatively inexpensive method to address important questions and more precisely define future research steps. And these results, this analysis, many times can shorten the measures to save future costs. I now am going to provide you with a few secondary analysis study examples. Now, I mentioned to you earlier about the seeking safety, which is a intervention tested for PTSD and co-substance abusing women patients. And the study itself did not indicate significant benefit of PTSD seeking safety intervention over well-crafted, well-delivered woman's health education. However, the secondary analysis from this data set revealed additional information and it generated publications, as you can see here in AJP back in January. What the secondary analysis has revealed was that the PTSD severity reductions were associated with substance use improvement, number one. Number two, the integrated PTSD SUD treatment may be advantageous for patients with severe symptoms. Now, the implications of these are far and profound, as you can see in the next slide, that in the same issue of the journal, there was an editorial on this particular study and suggesting that this is important in that brings into the question the common practice of requiring patients with PTSD substance use disorder to be absent from alcohol or drugs before commencing the trauma work. So this study challenged that conventional wisdom that maybe we should change our perceptions at the present time that these problems should be tackled altogether. And in that sense, which is a very, very important finding. Now, I'm moving now into the research utilization area of what CTN has done. As you can see, the research utilization or dissemination of evidence-based interventions is
difficult and slow. And therefore, plus the CTN has never had the mandate to and the resources to do the research utilization or dissemination part of the work. But that never makes this part of the work less important. In fact, it is probably the most essential element of the CTN activity, because without this effective research utilization effort, our impact on practice will always be limited. So our early conversation with Everett Rogers, many of you remember him, that he has proposed a low-cost, grassroots, and community-friendly model for research utilization. It is pretty much like a Tupperware party, that the community comes together. Instead of selling Tupperware, we can share with them of our research material and also our research experience. But we have never had the opportunity to test that. And perhaps in the near future, if you are interested, we should re-engage everyone to talk about this. Now, current CTN research utilization was led by the CTN Research Utilization Committee, and this committee was instrumental, and the committee members are incredibly effective with very limited resources, but very creative in serving our community. They support monitor CTN Dissemination Library. They serve as a point contact for NIDA Blending Conference, and also SAMHSA's ATTC program. And in the past 2 years, we want to start the regional workshops, and we have already 4 very successful regional workshops. The most recent one is in Baltimore. For those of you who have participated knows how wonderful that meeting was. And the next one is going to be in August in Los Angeles. I hope if you can, please participate. The next one, I just want to share with you the web link for the CTN Dissemination Library. It is all free. It's the treasure chest for all the CTN work. And in the very recent past, when we celebrate the CTN 10th anniversary, we also published the special edition from Journal Substance Abuse Treatment. It has a collection of many of our hard work in the past 10 years. I know every node has ordered hundreds of copies. If you're interested, please contact your node coordinator and obtain a free copy, and it is something to keep. The next one is a web catalog, like the cyber shopping catalog for all the CTN blending products. And you can get on it, and I'm pretty sure you can receive these things free. CTN Data Share. As you know, the NIH used taxpayers' dollars to conduct all the research. Therefore, it's a mandate for us to share our research product to have the widest utilization, and CTN has done it effectively, and it has had many downloads of our data across the nation and globally. And international outreach. In the past 10 years, as our research matured, our research products accumulated, and as you know that NIDA actually funding 85% of the global drug abuse research, so CTN's research products becomes popular and welcomed by the international community, and we were able to be very successfully working with NIDA's international program and created Invest Research Fellows. And in the past couple of years, as you can see, we were able to recruit and successfully train these research fellows. And many of them are very prominent scientists and health administrators from their native land. these people will be our liaison for future collaborations. And speaking of future collaborations, meeting global patient needs, CTN plan in the next couple of years to export our expertise and technology. Right now, as I mentioned to you, we have ongoing collaboration with Mexico and China, and with very near future, we will have potential international study sites in Italy, Brazil, Canada, and we are exploring HIV prevention study opportunity in China. So stay tuned. Now let me just briefly mention to you, do a little forecast about the CTN next decade. In terms of our infrastructure, as you know, the CTN's new direction is to really mainstream the drug treatment into medical practice for many good reasons. So we have been trying to expanding our CTPs to include other type of medical settings like emergency room, HIV clinics, HMOs, dental clinics, pain clinics, what you can see, what you can engage. Now, in terms of our future challenge and opportunities, whenever I talk about challenge, I always seeing it as an opportunity as well. Number one challenge and opportunity perhaps is the advancement of information technology. Now, there are novel approaches to data collection, processing, and storage. And the recent movement in development and deployment of digitized patient medical records that put us in a situation that if we do not get on the bandwagon with a interoperable medical records, then we may be left out by the healthcare reform movement. And so the CTN currently is taking the lead to develop standardized vocabulary terminologies for our medical records, common core data elements, and also looking into effective way to ensure patient privacy, confidentiality, and yet allow reasonable data exchange. And also we need to develop approaches to accommodate physiological and genetic information, especially the genetics information, and constantly developing innovative intervention to use web or wireless technology, because that's where we're moving. The other challenges, opportunities is that are some of the new trial paradigms. We talked about doing large, simple trials, comparative effectiveness trials, subgroup analysis. These were things that could enhance the service delivery. The most important thing is we constantly talk about addiction is a chronic disease, but we must develop chronic disease management model, and such as treatment algorithms for continuing care, and develop effective approaches for longitudinal follow-up, as we know that follow-up in drug abuse patients are notoriously problematic. In terms of doing trials, we have to constantly trying to explore innovative trial and study designs. The new statistical tools, techniques, like adaptive design, simulation modeling, large database mining are popular in many other therapeutic areas. We must see how we can adopt those in our research areas. And the process improvement currently is ongoing, as many of you are participating in the TEAM group within the CTN. We want to build consensus on meaningful trial outcome measures and success criteria, and standardize, harmonized tools, instruments, and training in instrument administration. These kind of standardization will facilitate future analysis and the future treatment guideline development and the future treatment practices. And if we drill down to the basics of our trials, I think in the future, we must ask a very different research question, the research questions that will actually impact practice. Questions such as what and for whom, how to best practice based on efficacy and side effects, and how to make decisions on how much time, training, cost is entailed in a new treatment. Is the clinical benefit worth the cost? Is there a cost offset? Only these questions answered that we can impact decision makers, policy makers to facilitate our work. So the questions, for instance, for chronic disease like addiction, what is the first line treatment? Is there a next best treatment sequence at steps 2, 3, and 4? And what sequence is best for whom? What is the long-term outcome after steps 1, 2, 3? And we can address these questions with what I just mentioned to you earlier, the new innovative design, statistical analysis method, and the data collection, and all of that put together, the future research will be different. So I think the future goals of the CTN, if I am not too grandiose, I'd like to propose that we should treat addiction as a disease and realize the promise of medication-assisted recovery. And we should engage in medical settings and the system in the treatment of addiction disease. In order to do that, we must effectively link addiction specialty treatment settings and systems with the primary care and other medical settings and the systems. And we must ascertain addiction treatment be included in the healthcare reform. And if we can do that, we probably achieved something important. And lastly, but not the least, I want to share with you of the CTN website, and I hope whenever you have time, visit us, and we are constantly updating this. So that being said, and I've taken so much of your time to share with you of our past accomplishment and our future goals. And I thank you for your attention. But most importantly, I, on behalf of NIDA directors and my colleagues at CTN, to express our most sincere gratitude. The truth is, without you and your extraordinary efforts, we would have not been able to have today's achievement. And this drug treatment field and the most underserved patients deserve our continuous efforts. With all your support, I'm confident we can achieve even more. Have a good afternoon and enjoy your summer. I look forward to speaking with you and meeting with you in the future. If you have questions, I'll be glad to address them. Thank you. Anybody has any questions?
If you have a question, please press *1 and the operator will attend to your line. Okay, Betty, I'm going to consider that silence is golden. I'd like to thank everybody for attending today. Betty, thank you very much for presenting for us today.
Definitely, and I look forward to speaking with you and meeting with you in the future. And if you're too shy to speak up with your question, please send me an email. I'm only an email away. I'll try to address them as best as I can. And thank you so much. And thank you for Emmis for organizing and conducting this seminar.
You all are most welcome. This concludes the session for today. Have a good afternoon, everybody.